let's talk upper abdominal disorders. This one's a banger right out of the gate because so many things can go wrong in the abdomen. Now, when you talk about upper abdominal disorders, it's very important to not confuse it with things that present with upper abdominal pain. Because look superiorly and inferiorly from the upper abdomen, and what do you have? You have the heart, you have the lungs, you have the lower abdomen where that dang appendix sits and the bladder sits, right? So please, 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 if I can impress 3 things upon you during my talk today, the first one is this: keep a broad differential diagnosis when someone comes in saying, I have upper abdominal pain. I will never forget this appendicitis I took care of, this lady with appendicitis. I didn't take care of her appendix, I took care of her. She comes in saying, I'm having 6 hours of upper, like epigastric abdominal pain and nausea and vomiting. Now, if you work in like a provider and triage model, how many of those patients have you seen and discharged out of provider and triage? Here's some Bentyl, here's some Zofran, here's your discharge instructions for your 6 hours of nausea and vomiting in this young, healthy lady after a negative pregnancy test, right? I was in fast track. This came to fast track for me. I gave her some medicines. She was pretty benign as far as her story goes, pushing throughout the abdomen. A little right lower quadrant tenderness, interesting, but predominantly upper epigastric tenderness here. She's not feeling better after a half an hour of Bentyl and Zofran and some time. And so, second point I want to impress upon you for upper abdominal disorders here is doing serial exams. You think it's something, do something about it, and then recheck them after the meds have kicked in and see where they're going. So I do a serial exam, and she goes, yeah, I got a little better, and then I started feeling worse again. And this was only like 45 minutes after the Bentyl had gone in. And I'm like, all right, something's wrong. I don't want you to go home because I think something else is going on here. I think you might have appendicitis. She goes, no, I think I want to go home. I said, okay. Here's point number 3. You have to give clear, timed follow-up instructions that are appropriate for the condition. So I told her, I said, I need you to come back when you're worse. And not in whenever, not in 3 days. If you are not better or feeling worse within 8 to 12 hours for this person with new abdominal pain, if you're not feeling better or if you're feeling worse in 8 to 12 hours, you need to come back to my ER. She rolls back in 6 hours after she leaves AMA, tachycardic, febrile, with a white count of 7. So you can't just draw labs and go, oh, the white count's fine. 10% of appendicitis patients have a normal white count, and she gets her appendicitis taken out. I'll never forget that. And that was upper abdominal pain, okay? So don't confuse upper abdominal pain with upper abdominal disorders, which we're going to talk about today. All right, esophageal foreign bodies. Patients have weird complaints sometimes, like bugs crawling out of their skin or their heart hurting, and you kind of take it with a grain of salt. But if their story is, I was eating something, I swallowed, felt something scraping on the way down, and now I feel pain right here, then that's one of those things you can kind of take them at their word for. They are very good. Patients are at localizing damage to the esophagus. You can see some danger areas here as far as places you don't want there to be perforations of the esophagus because of what's next door to the esophagus. So resist the urge of just kind of blindly shoving a nasogastric tube down into what could be a damaged esophagus. What else are you going to ding with that nasogastric tube? You really want to take a good look inside the mouth when someone, especially is saying, I have this foreign body sensation up there. Especially if the person, look at the middle picture here, is, I wear dentures and I had them in half an hour ago and now I don't know where they are. I found them, So you can often pluck out things from the upper esophagus here, from the oropharynx. What you have to be careful with, though, is this. You have to be ahead of the aircraft. This is an aviation term where you have to anticipate the next thing that's going to happen. So ideally, the next thing is you pull the dentures out of their mouth and they thank you and you discharge them. The horrible thing is they shift or you bump the dentures down, and now instead of having a pharyngeal foreign body, they have an airway foreign body. Okay? So be aware these procedures and retrieval things are not necessarily benign. Be ready, be ahead of the patient on this one. You don't always have to image the patient. if the sensation they're having is just mild discomfort. If there's zero respiratory anything, they're not coughing, they're not having a shortness of breath, they're not just in that kind of distress, they're in some mild pain, I think there is a good risks-benefits discussion that can be had if they can swallow well or just in some minor discomfort to having them follow up with the GI as an outpatient and clear follow-up instructions for a scope. And that's what's really needed usually is some sort of a scope. I love chicken salad. This person really likes chicken salad, right? They're saving some for later. This is an impaction, okay? So this person often doesn't just come in saying, it kind of hurts right here. No, they are holding an emesis bag, spitting, heaving in the emesis bag. We've seen these patients, some of us have. They look super uncomfortable, and they cannot go home. Often these folks have a history of this, and they know that when they eat certain foods, meat is a common offender. They can get things a little bit hung up, and they have their little maneuvers that they can kind of twist and turn their neck, and often that clears it for them. But often they're coming to you because all those things didn't work. Endoscopic retrieval is usually the way to go. Sometimes CT can be done, but honestly, if they're having an impaction, what's the point of shooting them full of rads when you know if you're not clearing that impaction that someone's going to have to go in with a camera anyways and get that out? So can't tolerate PO, GI's got to see them that day. If you're able to clear the impaction, then they need to see GI in the short order here. Because why? Because some studies suggest over half of these patients, over half, have some sort of anatomic abnormality here, a web or a ring, or God forbid a neoplasm that is causing the food to be impacted and hung up. So don't let them think that, hey, we cleared it and you're good to go living your life, never seeing a PCP or a GI ever again. No, you still need to go see a GI doctor even though we cleared it. So how can we clear that, right? What are some ways to do that? We've all heard about glucagon, the magical glucagon, okay? And studies suggest that you give glucagon and that'll improve your chance of clearance by about 10 to 12%. And that sounds okay, except if you compare it to doing nothing at all, your chance of spontaneously clearing is about 10%. So not a drug I can really advocate for very strongly, especially considering I give glucagon and a very common side effect. I think about 20% of those people will vomit. So think about this. I've got chicken salad crammed down in the esophagus, creating this closed space between the stomach and the lower esophagus, and I induce vomiting. And I increase that intra-abdominal, esophageal pressure here. Am I going to give them like a Boerhaave syndrome now? So be very careful in the glucagon thing, okay? Carbonation. Effervescent granules is the generic name. Easy gas is one of the trade names for this. It looks like Pop Rocks, and it sounds like Pop Rocks. It comes in a little packet. I get it from radiology. They use it for procedures there. The traditional way of using this is 240 mLs of water. You chase the Pop Rocks down with that. And some of you have overpriced bottles of 240 mLs of water sitting in front of you. That's a lot of water for someone who can't tolerate PO to try to swallow. Okay? That's going to come up all over your nice scrubs. So, what I suggest is this. Instead of that, right, you get 2 pill cups from the medication room. You put the easy gas, effervescent granules in the 1 pill cup, and you fill the other pill cup about halfway up with water. That's about like a tablespoon of water. And you do kind of like an Irish car bomb kind of a trick, like at the bar. You drop the easy granules into the water, and bang, they shoot it right there. And sometimes that is enough gas pressure to force the impaction down. Carbonated beverages are also okay to do that. Okay? They call them Cokes in Texas, but it could be anything you want, okay? Like, what kind of Coke do you want? I'll take a 7-Up. That's how we talk in Texas. Right? Something on the horizon here, perhaps, it's still kind of case studies, not officially recommended by anybody, dissolving nitroglycerin sublingual into some water and shooting that. And that makes sense, like mechanistically, right? It's a smooth muscle dilator. That's what we give it in terms of angina. So why wouldn't it work for this smooth muscle in the esophagus? Not ready for prime time yet, but it's an interesting thing to look out for. Button batteries, we're going to hit more on my oropharyngeal talk here, but a lateral view can be very helpful to distinguish between a button battery and a coin, because what you see on the side view often is this stacked pancake sign. You see this kind of little rim for the batteries, how they're commonly shaped. You can see timing is very important. 6 hours is how fast these things need to get out of there. And even if they come out, these patients are still very high risk. There is a case study about a child who had a button battery removed from their esophagus. 18 days later, the patient has a perforation, bleeds, and dies. So again, just like our impacted foreign bodies patients, even though you guys might be the hero that day and you get the button battery out and everyone's high-fiving each other, still very important you press upon these patients. They need to see close follow-up with a GI specialist about these. Once the battery has passed into the stomach, into the intestines here, a little bit less of a threat because it gets coated with poop, and so it won't do as much burning. Take a look at what's needed there as far as your serial exams. Esophagitis is a very specific diagnosis. And I almost wish, like if you put esophagitis in an ER or an urgent care emergency medical record, right, or electronic medical record here, I wish like that little paperclip from Microsoft would pop up and say like, it looks like you're trying to diagnose esophagitis without doing a scope. Are you sure you want to do that? Okay, because esophagitis is a very specific diagnosis. It's an itis of the esophagus. It's an irritation of the lining of the esophagus. Well, how do you know without direct visualization that this person's retrosternal chest pain is actually esophagitis and not an MI and not a PE and not a pneumothorax? You know? So I want to caution you about not using esophagitis unless it's already been confirmed by somebody else, because there is some degree of medical legal argument here that if someone comes in with chest pain and you say they have esophagitis, period, and you discharge them, have you excluded all the bad reasons for chest pain? Have you definitively excluded angina, okay, or other things like that, pneumothorax, whatever else here? So be very cautious when using esophagitis. Often we know about this ascending chest pain in people with a certain body habitus or dietary habits or whatever. Often that maybe is esophagitis from some gastroesophageal reflux, and there's lots of ways to deal with that, okay? The GI cocktail is kind of a famous one. You mix the lido with the Maalox and down it goes, but studies suggest the lidocaine can be skipped, and it does not provide any further relief of pain for an esophagitis, okay? Look at the very bottom line there. Don't get fooled either into thinking, I gave this person with some ascending chest pain a GI cocktail and a little famotidine, they're feeling better. It can't be something bad, right? Because why would that be fixed with, something I can get over the counter? Look, patients' bodies are weird, and they can fool themselves into anything. So there is case studies throughout the literature. It is littered, the literature is, with studies of people having bad outcomes because they had chest pain, got some GERD treatments, felt relief, and then the clinician, PA, NP, MD, DO, whatever, anchored on, oh, well, it must be GERD because it got better, and discharged inappropriately, okay? So be very careful. I have no problem with you giving it to them, even if you think it is, perhaps, maybe something more serious, because if their pain's better, like, hey, fantastic, like you made their pain better, that's great. Just don't confuse that with diagnostic testing. You're just trying to relieve their pain, okay? Pill esophagitis, let's talk about that real quick. So many different medications can cause esophagitis, especially if folks are running to a boot camp lecture and didn't want to buy that giant bottle of water for $20. They just kind of swallow down their medicines without a lot of water here. What's a common medication causing pill esophagitis? Anybody out here? Louder? I think I'm hearing NSAIDs out there, right? My friend Mike Sprosty is here. We go way back. Strong military PA. He knows our treatment for most anything in the military is 800 milligrams of ibuprofen 3 times a day. You're bleeding out, here's 800 milligrams of ibuprofen. Take it 3 times a day. By the way, drink water, change your socks, okay? I'm kidding. We've kind of gotten away from that, right? But heavy ibuprofen use or NSAID use can cause pill esophagitis, especially if we're not chasing it down with a lot of water. What are lots of pregnant ladies taking along with their vitamins here? Any sort of special supplements that can cause this? Iron, thank you, right? So iron is very irritating to the esophagus and the stomach, right? How about doxycycline? I took doxycycline every day when I was in Afghanistan to prevent malaria. I mean, I was supposed to. Anyways, I had a lot of folks come to me and say, Doc, I'll take the malaria over this doxycycline because it's tearing me up. I'm getting horrible gastritis, horrible esophagitis. I'm having the runs so bad, I can't deal with that. I also get sun sensitivity. I'm out in Afghanistan getting baked, okay? I can't do this, right? We are going to be using doxycycline a lot more in urgent care and emergency medicine because it is now the treatment for chlamydia first line in our non-pregnant patients. So it's very important you counsel folks when taking doxycycline about how to do that properly. We do an episode of the Two View about the new gonorrhea chlamydia treatments, and I talk about what you can do about doxycycline to hopefully get better compliance there. Gastritis was the name of the last slide here. Same thing. How do you know it's gastritis if you didn't look? Let's talk vomiting. I feel weird if I leave a shift and no one's been vomiting. None of my patients vomited. Right? Like, such a common complaint, right? Like, wow, 11 hours have gone by already, no one's been vomiting, I haven't had to give any Zofran today? That's ridiculous. Something's weird today. The top line is very important because, yes, sometimes Taco Tuesday is the cause of your nausea and vomiting, okay? Or sometimes it's that person who had something like this and they didn't wash their hands and you shook their hands, and now you have what they have, okay? But please, please, please do not assume a benign cause when it's vomiting. Ask about other things going on. Do you have a headache? How's your vision? Is there any blood in the vomit or the stool? Because look at all the things it could be, right? It could be some sort of hepatic or renal failure. It could be glaucoma. It could be cannabis hyperemesis syndrome. Let's talk about this. Who lives in a state where they've legalized marijuana? Who's really happy about that? Right? You're all of a sudden have to treat these patients who come in and you can hear them down the hall. You've already diagnosed them. You haven't even put eyes on them yet because you can hear them with their emesis bag and they're vomiting pure sound into that emesis bag, right? It's all, and you look in the bag and it's like empty. Okay? So like kind of one hallmark there of cannabis hyperemesis syndrome, of course, the marijuana use. Sometimes hot showers or baths improving the symptoms can be another hallmark here. And I consider it in my young and my not so young if they've been coming in multiple times for the same sort of thing, and records indicate not responding well to things like Zofran or promethazine. Because cannabis hyperemesis syndrome does not respond well to those traditional medications for vomiting. And cannabis hyperemesis syndrome patients do not respond well to your suggestions that, hey, maybe you're vomiting because you're a pothead. Okay, they don't like that at all, right? No, this is therapeutic for me, okay? And they might not even admit it to you when they do it. So you have to take kind of like a tricky approach here. You have to do kind of like a jab, uppercut approach to get to what you want. Hey, how often do you use tobacco? And I don't care really unless I'm assessing for cardiac risk. I'm just kind of softening them up here. And I'm saying how often, because it's okay to use tobacco. I'm not judging you. Do you or not? Like I'm a narc or something. How often do you drink alcohol? How often do you use recreational drugs? Not illicit or illegal. I'm not trying to entrap them into anything. I'm just trying to get good information out of my patients so I know how to treat them better, you know? And sometimes I'll still kind of like, they won't really admit to it, and I have to kind of go in with the last one. I'll say, look, like I don't care from a legal perspective because I think marijuana is a great drug. I think marijuana is a great drug, and its use in traditional medicine has so far just been untapped. Like, I want to make sure they know I'm on Team Green with them, right? And I did this one time with a guy, and he had his Asian mother in the room with him, a young gentleman, and I have an Asian mother, if you couldn't tell, and I would rather admit to being a mass murderer in front of her than saying I smoked pot. To disappoint mom, right? So finally I got her out of the room, and I asked him again. I was like, yo, I just got to know because, and this is what you say, like, look, I don't care from a legal perspective, but the medicines that I might use to help you with this kind of nausea and vomiting, I have to pick a different medication, and I just want you to feel better faster. The regular stuff is not going to work as well on you. I also want to get you better faster, feeling better faster, so you look miserable. And I do all that for this young man. The mom is finally out of the room, and he goes, after saying, no, 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 so you really think it's the marijuana, huh? And I'm like, I don't know, man. Do you smoke it or not? Like, let's go. Like, tell me yes or no. So what do we do about that? Haldol, 5 milligrams IV, is a very useful drug for cannabis hyperemesis syndrome here. Applying gently, sparingly for the first time, capsaicin cream derived from peppers to the backs of the arms and the abdomen is also helpful. Just don't rub your eyes after you put it on, right? Those are great ways to turn lions into lambs here as far as these roaring, scream vomiting patients into very good about half an hour later. Except one of the issues there is that it can promote some long QT syndrome. So especially if the patient already has some, congenital long QT, especially if you just hit them with Zofran before you recognize what was going on here, because Zofran can also induce long QT. Just be careful with that. Honestly, I'd rather just wait a little bit and get a good history and then give them Haldol early if I think it's really what's going on here instead of doing Zofran first. Because like half an hour later, these folks are just feeling awesome, okay? Well, what can you do in the meantime for any of these nausea and vomiting patients? You find an alcohol swab, and they're in the back of every single drawer in your ER and urgent care, right? Just pull it back far enough, you'll find an alcohol swab back there. Rip it open, hand it to the patient, and at minute 1, you can be starting to resolve their nausea and vomiting symptoms. Ken Milne, one of our faculty educators here, runs a fantastic blog and podcast called The Skeptic's Guide to Emergency Medicine. I'm going to be repping it a lot during my talks just because you can find a lot more information about things I'm going to briefly cover on his blog, and that's one of them. The inspiration of the alcohol swab over Zofran and how it's like equivalent in terms of relieving nausea and vomiting really early on. So don't sleep on those alcohol pads, okay? What else can you use? Zofran, a big choice often in our early pregnancy patients here, but you can see it can cause problems with oral clefts in the first trimester, also covered on Ken's blog and podcast. So I like going with the Reglan, with the metoclopramide early in our hyperemesis gravidarum patients, our pregnant and vomiting patients here, okay? Compazine, if you go by the category A, B, C drugs for pregnancy, Compazine considered a class C for pregnancy, but it's for third trimester use and heavy use. So you can use it great early on in pregnancy, okay? Promethazine, kind of dicey, be careful with that. Dilute it, give small doses. It can cause some tissue necrosis if you infuse it IV. A lot of folks won't even let you do that. You got to go IM or nothing at all, okay? GI bleeding, we've all heard this before. If it's red from the bottom, it's from a lower site. If it's dark and tarry, it's from an upper site, okay? That's hematochezia versus melena here, all right? It's not always the case. Sometimes there are issues with rapid transit, or someone's had like a hemicolectomy, and there's less tubing to go through, or just heavy bleeding. You'll get bright red blood from an upper GI site. So these are rules of thumb, but not really things you can for sure go off of. Important to distinguish between Mallory-Weiss syndrome and Boerhaave syndrome. So Mallory-Weiss syndrome, the classic story is, I've been vomiting, and finally with the last episode of vomiting, there was a little blood that came out. And that freaks people out, understandably, right? Usually that is Mallory-Weiss, some superficial erosion of the esophagus causing a little bit of bleeding. You get the vomiting to stop. Usually that heals up pretty well. Let's contrast that with Boerhaave's, where you have kind of like violent vomiting and then horrendous chest pain. These patients often look very sick. They've torn a hole through the entire, depth of the esophagus, okay? And if you can imagine, the things outside the esophagus and the things inside the esophagus shouldn't mix a whole lot. That's not good, okay? So these patients get sick very quickly. Contrast that with varices, right? So varices, just like varicocele and varicose veins, these are kind of dilated veins in the lumen of the esophagus. Can happen often in patients with some sort of liver issues. So think about hepatitis, ask about things like alcohol use, feel for some hepatomegaly, and that could give you a clue of, oh, this larger volume vomiting that is not quite stopping with traditional antiemetics, lots of vomiting coming out. This is a more serious patient. These patients can get sick really quickly as well. They bleed out from a place you can't compress. I'll take someone bleeding out from a leg or an arm wound all day long because I can tourniquet that off, but it's really scary when they're bleeding from the inside. Okay. Lots of labs can be done. I would be very careful about how much normal saline or ringer lactate you're going to give these people. These people need blood if they are really bleeding and not salt water. So maybe a little 500 ml bag of that, but you're looking early to pull out some blood here and drawing some labs you need to do to get that blood cleared. And we think, oh, well, if I need rapid release blood, I go to the O-neg. That's our classic O-neg. But think about it. If you're a gentleman, or if you're a lady who cannot deliver babies, there's no uterus, or you're well past childbearing years, it's okay to give O-pos blood. You're not going to have that alloimmunization you might get by mixing Rh-neg and pos blood here. So consider saving the O-neg blood for our younger females of childbearing age still. You can consider famotidine, you can consider protonics, pantoprazole, and the classic thing you do in GI bleeds and ERs is you're going to give 80 milligrams IV of pantoprazole and hang another 8 milligrams an hour, except that's not really shown to improve outcomes in an active GI bleed. So maybe you do it because it's local practice. I feel like there's a lot of kind of shifting away from reckless PPI administration because we're seeing some things we don't like about PPIs. So just kind of be aware of what's locally accepted. Do you have to do that? Will GI get really mad at you or whatever? Or can you maybe hold off if you don't think it's necessary to do? NG tubes, be careful. Be careful about NG tubes here. We're kind of seeing less and less indication for those. There's a lot to look at here. The thing I want to highlight is on line 2, possible hypocalcemia. A lot of considerations now about how the lethal triad of trauma should now be considered the lethal diamond because we're seeing a lot of folks who are bleeding out a lot, going low on calcium, and that causing problems. So read more about that and see, hey, should I be giving calcium along with this? Okay? PRBCs are great, but they're not whole blood, and so you need to give all the other stuff that's in whole blood if you're giving a whole lot of PRBCs. Pancreatitis. We talk about it a lot on the 2View. I did a great review of a recent JAMA clinical review on pancreatitis. It changed my practice on pancreatitis here. What's going on pancreatitis? Your body is digesting itself from the inside. Your pancreas makes enzymes that dissolve carbohydrates and fat. We are made of carbohydrates and fat, okay? And so it's eating you from the inside if you have a pancreatitis here. And you can see this can cause things like severe inflammation, SIRS, ARDS, shock, and even death. Lipase is our money test we're going to get to in a second here that often shows us in acute pancreatitis patients, hey, this is what's going on, it's a pancreatitis. Usually 3 times the limit of normal is what we're shooting for to kind of more lock in our diagnosis here. We know the common causes alcohol, gallstones, sometimes triglycerides, but there are a ton of even like Tylenol can trigger pancreatitis. Marijuana use can trigger pancreatitis. But doesn't that look like cannabis hyperemesis syndrome? So again, don't anchor on, oh, you're a pothead, you must have cannabis hyperemesis. You might have pancreatitis. Looks very similar, right? Pain and, refractory nausea and vomiting. If it's early in the course, like it's that day, I'd go ultrasound. Because ultrasound has been shown in one study to change the course and what you have to do for this patient disposition-wise in about 50% of patients. There's no RADs with ultrasound. You can even do it bedside if you're adept at that thing. So I am doing ultrasound for a lot of these pancreatitis patients. CT scan, the things you're going to find in a less sick patient with pancreatitis on CT, they don't really show up until about 2 or 3 plus days later after the onset of symptoms. So judge when the patient started having symptoms and ask yourself, do I really need to get a CT on this patient in the ER? If they're coming into the hospital anyways, that could be a thing that the hospitalist team can do, and you can clear this patient out of a bed. Okay. I'm pretty close hold on IV rehydration unless your vital signs are really screaming at me, but I'm very aggressive with my pancreatitis patients with IV rehydration, okay? I'm also very aggressive on pain relief. I'm giving high doses of usually opioid-level pain relief for these patients here. We used to say for pancreatitis patients, you're going to want to rest your GI tract. So just, drink broth and Powerade for the next couple of days if we're going to send you home here. Multiple studies are showing recently that early PO intake, eating food you can tolerate on the first day of symptoms, actually reduces mortality. Okay, so be aware of what's in your discharge instructions, what you're telling the patients that you're sending home with pancreatitis. If they're not looking concerning, and we'll talk about what that looks like in a second, and they can tolerate PO, they can be controlled on PO pain meds, maybe you can send them home if it's not their first time at this rodeo. But tell them it's okay to eat, okay? We know about Ranson's criteria, and we know that half of Ranson's criteria to assess for mortality risk for pancreatitis, that half that's obtained in the hospital after 2 days of being in the hospital. Not super useful for emergency medicine clinicians. So some new scoring criteria for risks of pancreatitis mortality here is this BISAP criteria. You have less than or equal to 2 of those things positive, you have a less than or equal to 2 chance of mortality. Okay, so a low number is good here, all right? Some studies suggest SIRS criteria is enough to know if this patient's going to poop the bed down the road. Okay, if they come in and they're tachycardic, febrile, tachypneic, all the SIRS criteria, right? That may be enough. So maybe if you're going by BISAP and their 1 point that they earn is because of SIRS, maybe you don't use that BISAP rule. You consider bringing them into the hospital. Again, if you go to our 2View website, I've got all these kind of linked for you there, 2view.fireside.fm. You will not see Cullen's or Gray-Turner sign in your happy, mild pancreatitis patient. These are very sick patients. It's nice if you think it's pancreatitis just to take a quick peek, to look, to make sure, but no, these are patients with, hemorrhagic pancreatitis. They're very sick. You're going to tell walking into the room how sick these people are, and so very rare in our mild pancreatitis patients. If you see this, they should not go home. Hepatitis, we think of like hepatitis. I got my shots for that, but I haven't vaccinated against that. But a lot of things can cause hepatitis beyond viruses, and you can see them there, okay? These are, again, kind of nonspecific. I got upper abdominal pain, some nausea and vomiting. A lot of these folks can go home. But you still want to do a good history and physical to try to assess why this might be going on. So if there's any sort of correctable risk factors, you can kind of cut those out. You're doing some tests. And those are our admission criteria here, right? If they are not mentally with it, that suggests something bad. Our AST, ALT, our ALK phos, our Biliary, we call these our liver function tests, right? These are really our liver injury tests. They tell us when the liver gets nicked by something. What does the liver do? Well, among other things, it helps to stop bleeding. And so really our PT, PTT, INR is our liver function test. So if you're worried about hepatitis, this patient especially, it's good to get a coag panel on that patient here. And other reasons for admission down below. Bilirubin being elevated here, even if they're pretty mildly symptomatic, it's a reason to bring him in. Patient the other day I had looked like he belonged out front at Caesars. He was bronze from head to toe, okay, eyes and skin, had a bilirubin of 20. It's generally bad when bilirubin is measured in 2 digits, okay? So that person came in even though they're pretty mildly symptomatic. Gallbladder disease is a pretty common thing. A lot of them related to gallstones, and depending on where these stones get kicked out of the gallbladder, they can cause other problems, not just gallbladder problems, but liver problems and pancreas problems as well. And just like in the appendix, you get a gallstone lodged in the neck of the gallbladder. It causes localized inflammation, which leads to infection, which leads to badness. Okay? And you can see on the right side of the slide all the places stones can get hung up, and you can imagine kind of back pressure and stasis of these bile acids, how it could cause problems upstream from where each of these stones is lodged. Ultrasound's great to do, and for a while I kind of struggled. I think this is biliary colic. Do I ultrasound this patient? Because sometimes it adds a lot of time without a lot of gain to our stay here. If it's only been an hour or 2 of symptoms, and it's already kind of getting better, and they look well as far as vital signs go, and your presentation is not super concerning, you don't get a Murphy sign which is what's called arrest of inspiration. You push on the right upper quadrant, they take a big breath, and it kind of catches them in their tracks as they breathe in. That's true Murphy's sign. Not just, oh, it hurts worse when I breathe in. That arrest of inspiration is your true Murphy sign, okay? If none of those things are there, very short time period, already getting better, probably not necessary to do an ultrasound if your labs check out. But if it's already been 6 hours, 12 hours, 24 hours, the pain's getting worse, that suggests something is stuck. And so you go ahead and order an ultrasound, in my opinion, early on those patients. A brief mention of Acalculous Cholecystitis, pretty rare. Acalculous, no stones. It's often something else causing this problem here. Ascending cholangitis can be caused by a stone in the biliary tree. You saw that graphic a few slides ago. I've seen patients with jaundice and right upper quadrant pain, like that gentleman I was telling you about earlier. And I've seen patients with fever and right upper quadrant pain. It's pretty rare you get all three together. And when you do, that Charcot's triad, very concerning for something very serious going on there. If there's no signs of inflammation based on your labs and your exam and your serial exam, remember that point number 2 from earlier? Serial exams are looking good too. Often these folks can go home if they can, be controlled by oral pain medications and their PO tolerance, stuff like that. Okay? But if we're seeing signs of inflammation, whether it's on labs or exam, they're getting worse on serial exams here, we're calling the surgeon for those. Again, 3 points. Keep a broad differential diagnosis on people coming in with upper abdominal pain, because it could be anything, upper or lower than that. Serial exams, and important to give them good timed follow-up instructions.